Okay, I think we're now live. So good evening, everybody. It's lovely to see you all and welcome to this Facebook Live session. We're joined tonight by three wonderful expert speakers. I'll just briefly introduce them, but when we come to them, I'm sure they'll introduce themselves as well. So we've got Professor Laura Coates from Oxford. We've got Dr. Mark Perry from Plymouth, and we've got Dr. Gavin Cleary from Alderhay up in Liverpool. So fantastic speakers for tonight's session, which is going to be on something called PIFU. Now, what is PIFU? I can hear you all shouting at the screen. Well, it stands for patient-initiated follow-up. You might also hear it being referred to as patient-initiated return, or patient or rapid access, or direct access. There are various ways in which it has been described. And basically, it means that you could be selected to go onto this kind of pathway if you meet the criteria. And I'm sure we'll come on to discuss the criteria when we start the discussion with our experts. And what would happen is that you would be given a follow-up for approximately, let's say, 2 years' time. And if you need to get in touch with your team in advance of that 2-year appointment, for whatever reason, you might be flaring or there might be some problem with your medications, then you get in touch with the team and you make the decision to have that contact with your team. So before we engage with our experts, let me put this into some kind of context for you in regard to national policy drivers, because I think it's important to understand what is driving this and other changes to rheumatology care post-pandemic. So these and other changes to more remote ways of delivering care can seem quite complex. So I think it's just worth taking a few minutes to explain a bit more. Following the COVID-19 pandemic in 2020 and 2021, there's been an intense period of NHS service redesign generally, and this very much includes rheumatology. PIFU isn't an entirely new concept for rheumatology services, and we'll hear more about that from Mark in a little while. A number of services have offered open access follow-up with patients contacting the service for advice or requesting that their appointment gets pulled forward via a nurse-led telephone advice line. However, what NHS England are saying is that these informal open access arrangements were increasingly challenging to provide even before the pandemic. The NHS England long-term plan highlighted the challenges and the frustrations for both patients and clinicians in relation to traditional outpatient delivery models, where you typically would have a routine follow-up, maybe 6 or 9 months, irrespective of how you might be at that time. And they're arguing for people to have more control over their health and more personalised care when they need it. I'm sure many people listening tonight will have the experiences as I have, where you possibly have to take time off work and trek to the hospital for your appointment, only to tell the doctor that everything is okay and nothing really needs to change in your care. So the appointment becomes a waste of time for you as a patient, for the clinician, and also represents an unnecessary cost to the system. Wouldn't it be better to be seen when you actually need to be seen? So patient-initiated follow-up describes when a patient who's already under the care of a service or a carer on their behalf makes contact with that team and, if required, arranges that appointment. PIFU is one aspect of a personalised, stratified follow-up approach, which is now being successfully rolled out in cancer care, for example. Within rheumatology, PIFU can be supported by digital remote monitoring of patient-by-patient reported outcome measures, for example, being filled in and maybe sent back on your smartphone or various other means, and also monitoring digital patient safety. In the 22-23 priorities and operational planning guidance for NHS England, it states, and I'm reading you exactly what NHS England is saying here, a more personalised approach to outpatient follow-up appointments will ensure that people who require a follow-up appointment receive one in a timely manner, protecting clinical time for the most value-adding activity. And the guidance also specifies that providers and systems are asked to accelerate progress towards a more personalized approach to follow-up care in hospitals and clinics, reducing outpatient follow-ups by a minimum of 25% against 2019-2020 activity levels by March 2023, and going further where possible. They want to expand the uptake of PIFU to all major outpatient specialties, moving or discharging 5% of outpatient attendances to PIFU pathways by March 23. Now, just finally to explain that these are overall targets for systems and trusts and the individual providers, the individual hospitals within each system. So in any one provider, whether providing pediatric or adult services or a combination of both, rheumatology specifically doesn't have to move 5% of their outpatient attendances to PIFU pathways by March 23, providing the organization, so the trust as a whole, which might be several hospitals, achieves this across all specialties, so not just rheumatology, although I suspect that rheumatology is going to be a big target for this kind of pathway. And this flexibility is being built in because the guidance acknowledges that a 5% target may be more or less appropriate for individual specialties within an individual provider, depending on their patient pool. Now, this may be happening in other devolved areas, Scotland, Wales, Northern Ireland. I don't know if they've had targets set in those areas, but I do know discussions are going on in the devolved areas as well. So whilst I've been talking about NHS England, I think this is going to happen gradually over the whole of the UK. Now, Laura, perhaps if I can come to you first, because I know, because NRAS, we're involved in this study with you. I know you're doing some research into PIFU at the moment, just setting things up. I wonder if you could tell us a bit about that and why you're doing it, and what the key things are that you're going to be looking at.
Yeah, so I'm a rheumatologist based in Oxford, and I'm a researcher as well. And traditionally, most of my research has been in psoriatic arthritis, which is why I haven't reached out to NRAS before. But we obviously are aware as clinicians that we are getting a lot of targets and advice around PIFU. And it really became clear when I looked at some of the evidence and raised some concerns that we have quite limited evidence really on how well PIFU works, and particularly who is suitable for PIFU. So there will be some patients who do really well on PIFU, who it suits, and you've outlined some of the advantages. You don't have to come when you're well, you get to come when you need to come. It all makes sense really. But there's always a bit of a concern that some people may not do as well, that they may not be confident enough to ask for help at the right time. They may request too many appointments or too few appointments, and that disease might be missed. And so I approached a group of clinicians initially and patients now back in the autumn to say, if they're going to roll out PIFU, which is definitely happening, shouldn't we do some more research and try and embed research as we roll this out to learn more about it? So we've got a great team together. We're applying for funding this week. So once I'm finished here, I've got lots more writing to do with a deadline on Friday. But we've got a team of rheumatologists, of psychologists, of patients who have rheumatoid, psoriatic arthritis, and representatives from AXPAR, ankylosing spondylitis groups. So it's sort of all across different types of inflammatory arthritis. We've got health economists, statisticians, and we're trying to look at PIFU really in as many ways as we can. Nice. So there's kind of four main things that we're aiming to do. One is to create really good, high quality educational materials for both patients and clinicians about PIFU, because a lot of trusts have been developing these kind of on their own, and actually it makes sense for us to try and bring people together and create something optimal with the rheumatologist and the patient so that it makes sense. We're going to look in routine collected data, so data, for example, from your GP records, to look at how people do on PIFU. We're going to run a trial of PIFU versus standard care. So if you are in one of our potential study centres, then you may be asked about that. we will randomly divide people into two groups, one who switch to PIFU straight away and one who get a 1 year of normal appointments and then switch to PIFU after a year. And then what we want to do with all of that data is bring it together at the end with a lot of patient interviews and clinician interviews to try and work out who does best. How do we select the people up front? How do we know which patients will be confident enough, will be happy at managing their disease, will know when to seek help? And they're the ones that are ideal, I think, for that kind of PIFU follow-up.
Right. And what, in so far as the discussions that you've had with various colleagues putting this research together, what would you say has struck you as, you know, have you had any sort of alarm bells ringing about this in terms of, you know, we know what the advantages are, but we're not quite so sure perhaps what some of the disadvantages might be, although I dare say Mark will have a view on that as well.
Yeah, so there are 4 studies so far that have looked at PIFU over the last sort of 10 to 15 years. And one of those was in the UK, another 3 were in Europe. They were all with patients with rheumatoid arthritis. So we've never looked at this in patients who don't have RA. There are no studies in JIA or psoriatic arthritis or ankylosing spondylitis. So we want to include kind of all those different diseases so that we can learn more. I think pretty much all the studies, so we've done a special analysis, putting all those 4 studies together and trying to look at their results, almost imagining they were one study and combining them together. And when we look at the data overall, there doesn't seem to be a huge difference in most outcomes between the 2 groups. Generally speaking, the PIFU reliably decreases the number of appointments that people ask for, that people have. But the other outcomes, so tender joints and swollen joints, quality of life, pain scores, things like that, all look roughly equivalent in both groups. And I think when I've been discussing with Mark, with Elsa, with a number of different people who are involved in this grant, most of us feel that it's not that PIFU is the answer for everyone or that old-fashioned standard follow-up is the answer for everybody. It's trying to get the right person on the right program. It's trying to make it suit you. And so that's officially, we're designing the study to show that PIFU is better. That's our statistical test, that PIFU is better than standard care in terms of health-related quality of life. So a patient-reported measure about how you feel and how your disease impacts on you. And we may well show that it's better. So patients may be more confident and happy, feel like they're managing their disease and feeling happy about the way they're being cared for. But we might not show a difference overall. And I don't think we would be that surprised or concerned if we saw a similar outcome. Then we want to look at who does best. So how do we select those patients? And also, how do we help patients? So maybe there are some patients who don't feel confident about PIFU, but if we're providing the right education and support and information about when to call, how to get in contact, how long you should wait, how quickly you should be seen, that kind of information, then maybe after that support and education and help, patients will feel confident and will be happy to move forward with PIFU and will do very well. So there are a lot of the things that we want to look at. And
how long is this all going to take?
Oh, a long time. So we haven't got the money yet. That's the first issue. So if anybody's got a large checkbook, you can contact me at the University of Oxford. We are asking for a very large amount of money, probably the largest amount of money I've ever asked for on a grant before, on Friday. So hopefully they see that we really are doing a lot of work around this topic that will be helpful, not just for rheumatology patients, but will help us learn how to apply this in inflammatory bowel disease and lung problems and that kind of thing. Once we get the money, we're aiming to start this grant in December to open the trial next year. So we'll have patients randomized to standard care or to the PIFU group. And we're going to look at outcomes every 6 months. So our first outcome will be at a year, but we're going to follow people out to 3 years. So the whole study is going to be 5 years-ish. but we're aiming to look at outcomes kind of as quickly as we can moving through. We want the long-term outcomes, but because this is happening already and we kind of don't want to miss the boat, we want to look at outcomes at 6 months and at a year, and look at who's being put on to PIFU even quite early on, so that we can learn something and feed that back to clinicians and patients and support them.
Okay, that's great. Thank you, Laura, for the moment. So, Mark, let's come to you, because I know that you're one of the early adopters, if you like, of this kind of approach, going back some years now. Could you tell us a bit about what you've done in Plymouth, when you did it, how you did it, and what some of your results have been?
Yeah, well, thank you very much, Elsa, and others for inviting me tonight. It's a real pleasure to be representing my team here from Plymouth, just on the edge of Dartmoor. And I'm sorry if the sun streams in at times. We do sometimes get sunny weather down here. So about 20 years ago, I was involved in a study when I was still a trainee in Bristol, and that really got me first thinking about this sort of process, and how might some people in some circumstances find it easier and better for themselves to access care in a way that was more timely and suited them. When I was appointed as a consultant in Plymouth, if you like, over those 2 or 3 years after I first got here, we were quite a difficult place, I think, as a department, for a number of different reasons. In some ways, sort of, there are lots of echoes now in what I see in the whole NHS of what we experienced in Plymouth about in the late noughties, early tens. And that really focused our minds in the same way that if you think that we've got now as a nation as to, well, what are we actually trying to achieve, and in what way might we achieve it? And that then brought me back to some of the evidence that we had from the first of the trials in Bristol. But evidence is not this kind of set thing. Evidence sort of evolves, and so, if you like, I tend to think of best available evidence. And when we were in sort of 2010, 2011, as a team, we sat down as a clinical team. We worked with our local patients in the NRAS group in particular, who helped us kind of co-produce something which we're really very proud of, in terms of trying to fix the problem that we had at the time, which was that a lot of patients who couldn't access care in a timely way, as I say, echoing a lot of what we can see wider now, but also a clinical team that itself was in quite a difficult place, and that itself can cause all sorts of problems, because teamwork is so much of what we do. So we set out to produce what we now call direct access, which is a PIFU service. We had about 300 people initially, where they had a easily applicable diagnosis to the evidence that we had, the best available evidence that we had, who had rheumatoid arthritis. And then over the 10 years since then, we've gone from about 300 people to about 2,000 people out of a total follow-up group in our service down here of about 6,000 people. So it's about 30% of the people that we follow up. And there's lots of other information. Quite a lot of it's in fairly plain English, but there's also some more sciencey stuff on our website if anybody's interested. So what we have now is what we think of as a sort of 2-week wait, 2-week kind of chronic disease wait, if you like, because there's a number of different conditions that we use related to rheumatoid and other related inflammatory artery disease. Prior to the pandemic disrupting everything, people would typically, phone in or email, and they'd come and see me if it was me, or one of the specialist nurses if it was them, or one of my consultant colleagues if they were under their care, and they would typically see them within 2 weeks. There have been bumps in the road over the years. It's all in a fairly plain English case study, which you're welcome to have a look at on our website. But prior to the pandemic, it was a fairly standard within 2 weeks, and we'd support each other as colleagues, but typically people were still under a particular consultant. In the last 2 years, there's no doubt that it has been a lot more challenging to do all sorts of things in life, and you'll be well aware of that. And so that's brought quite a lot of turbulence to what we do. But even at the very worst periods during the early few weeks of the pandemic, when our almost entire department, rheumatology department, was turned into fracture clinic, even with the 1 room rather than 10 rooms that we normally have, we were still seeing people face-to-face when required within about 4 to 6 weeks. And really, right from the summer of 2020, we've been back to seeing people within 2 to 4 weeks. And now most people who I see, if they've needed to come and see me, would be within 2 or 3 weeks, unless I'm away for 2 weeks, in which case we talk with them and say, well, the nursing team talk with them and say, well, what is it you're after? Is it something that actually somebody else could help you with? Maybe, for example, a knee injection or something fairly sort of technical, if I can call it that, or is it a bit more sort of long-term strategy, and would you prefer to see somebody that might be 3 or 4 weeks when they're available, but it's more of a strategy, longer-term issue that you want to talk with them about? So you know, we have a well-functioning 2-week wait. Most of the time, there are bumps in the road. Clearly, doing anything at the moment is hard, and I'm not suggesting we don't have any backlog. We also have 40% of our consultant staff vacancies for the last 3 years, which itself does make for its own problems.
Yeah, I think the backlog is horrifyingly large at the moment. Every consultant I talk to gives me numbers with lots of noughts on the end, and it is very worrying. I suspect that some of this is being driven, would you agree, by backlogs and trying to, this is one of the ways in which one could safely perhaps reduce those backlogs a little bit faster, but it is going to take time to implement this kind of pathway, especially with the kind of education that you perhaps need to do with patients. What have you done in terms of education for your patients who go onto this pathway, Mark?
Yes, thank you for that question. It's evolved over the years. And again, lots of the detail are on our website, but it started off with one of our specialist nurses who was very interested in trying to help us develop this from scratch, really, who would meet with a number of patients face-to-face. This is 2010. And one of the benefits, and she would talk through with the nurse, with the patient group. It was a sort of group education, if you like, maybe between 6 and 10 people, I think, from memory, although it's some years ago now. And not only could they hear about how we were proposing that we might change things locally, it also really enabled a sort of re-establishment of trust after these bumps over a number of years of people not being able to access in a timely way and all the pressures that put on. And then over the next 6 years, we moved from having groups of people, which were the first 300 people. So we got through them over a number of 2, 3 or 4 months. I think we sort of got through them on a kind of weekly group clinic sort of way. We then went to training one of our very talented healthcare assistants to be able to answer most of the questions with an available specialist nurse, because a lot of it is about the mechanics of how does this work? Who do I contact? What happened? You know, what's the safety net if I haven't heard back? So it was that sort of mechanics of it, with a specialist nurse available, if you like, in the next room, so that after the, I don't know, hour or however much time they'd spent together, you know, Nikki could come in and speak about the specifics, or answer any specific questions. And what we have now is one of our rheumatology medical trainees about 5 years ago, actually produced a YouTube, which is again on our website if you're interested in seeing it, which is, if you like, what I typically do now. And that we introduce the concept of patient-initiated follow-up, or as we call it, direct access. We introduce it sort of towards the end of our 2-year early arthritis pathway, maybe from 12 months to 24 months, so the second half. So as people often are becoming much more confident in, if you like, how they are getting back to a lot of their more normal activities, we introduce the concept of stretching out appointments, and this is the sort of thing we talk about. And I typically would say to somebody, could you watch this YouTube before the next appointment and I can answer your questions? Or sometimes, actually, if I see them in clinic and there's time available, you know, I ask them to watch it. And the real benefit of them watching the YouTube is not to try and depersonalize it, but to try and standardize the information that people have. And to therefore mean that it doesn't depend on me being there to answer their questions, or if it's another health professional, but it's about trying to standardize what we do. And one of the real wonderful things in the last 18 months, and particularly the last few months, and being involved in the current research that Laura was talking about before, is that this evolving body of research, which 12, 15 years ago was just one study, and then there have been various ways of sort of sort of condensing various information from a number of studies in what are called systematic reviews, and you sort of block it all together, and all the details are on the website, and something called a Cochrane review. But those are across a number of illnesses, and now the opportunity, really a once in an NHS opportunity, as this quotes change happens to all of us, is that we can try and capture as much information about, assuming the grant is successful, which I very much of course hope it will be, we can try to capture as much information from the changes which are happening, frankly, whether we like it or not, some of which are definitely for the better. But bear in mind that about March the 28th, I can tell you exactly where I was when I suddenly realized that, having spent 10 years trying to get people to think about PIFU, could this be something that we might consider? It completely pivoted to, I was thinking, well, how am I going to actually enable people to be protected, patients to be protected? Me, I have a long-term condition, and I sometimes want to access healthcare, not inflammatory arthritis, but I sometimes want to access healthcare, and I quite often don't want to have to remember about it. I want to get on with something that are my abilities, rather than things I can't do so easily. And it pivoted just in that week at the end of March, from trying to get people to think about it to trying to help people doing their best, but often uninformed, well-intentioned, sometimes managers, just quotes doing something because it's the target. I mean, you have to remember, to date, in inflammatory arthritis across the whole world, there are only just under 1,000 people who've been in studies where we've actually tried to measure things, even in the best available ways that we can. Whereas suddenly PIFU is being generalized to 68 million people. Well, the difference between 1,000 people and 68 million people is lots of noughts. I can't quite remember what percentage that is, but not everybody is the same, and we are all quite different in how we go about things. So it's great to be able to kind of, well, I remember sitting at this very desk in 2009, tapping the information in, saying, would you consider evaluating the study to PENARC, which was my collaborators down in the peninsula. And now to be able to think, well, how could we look at it more systematically even than we've got at the moment, for the very reasons that I would agree Laura's articulated. We know some stuff, but there's a heck of a lot of stuff we don't.
Oh, yes. Well, thank you for that. That's really, really interesting to hear from a PIFU that's been in place for so many years. So Gavin, let me come to you. I would say that in the work that I've done in JIA over many years, I've always had the strong impression that families and parents and carers pretty much will always contact the team if there is something wrong with their child, because a parent will be much more concerned about a child's health and well-being than they would necessarily about their own. And I think that's generally true. Adults are a bit more cavalier about our own health and our emotional well-being and so on than you would be with a child. So is PIFU complete? I've not heard of PIFU in the context of pediatric rheumatology before. Is it new to you? Has anybody done it in pediatric rheumatology before? So what's your take on all of this?
Thanks, Ailsa, and good evening, everybody, and thanks for the invitation. So yeah, so I'm a paediatrician looking after children and young people up in Liverpool, and the term PIFU is definitely new to us. And when did we come across it? Probably the late autumn of last year. But the context, as Laura and Mark have just been talking about, the context of patients initiating follow-up by calling a nurse-led helpline, by calling our pathway coordinator to arrange a follow-up, of course, is not new to us at all. So we were approached by NHS England with the first children's unit to actually initiate a PIFU pathway. As Laura was suggesting, one of the first things we did was, of course, look for some evidence, look in literature for evidence, and there isn't evidence for children and young people with JIA. So, of course, we started to draw evidence from the adult experience, and in paediatric rheumatology, we don't often like drawing evidence from adult research, because children and young people are not just small adults. They are, you know, they are very different. But we were very persuaded quite early on, when we started to think about developing PIFU, that this was truly an opportunity to improve the experience, at least, of our patients. Elsa, as you know, we're not driven by backlogs in the same way as our colleagues in adult services are. We don't have the same volume of patients, Anna. That's not to say that we don't have challenges with capacity at times, but we very much taken that this is an opportunity to improve the experience for our patients. Because we run tertiary or specialist services for children and young people, we often have patients who travel 3 or 4 hours for an appointment. So an outpatient visit is a whole day out of school, college, or work, education for parents. And of course, often that can be for, as you alluded to yourself, Elsa, just for a quick, oh, great, everything's going fine, blood tests are okay, carry on. So in the same way that we sense that remote consultations for the right patient at the right time, it can work very well. We think PIFU can work very well for the right patient at the right time. But equally, there could be scenarios where it could be potentially, there could be some very unexpected adverse effects. So we've built our pathway with some very strict criteria. So we are looking at children and people with JIA, whose we've known for 2 years, whose disease we can categorize as stable, who we know have got the ability to initiate contact with service. We've got a good infrastructure of nurse-led daily helplines or pathway coordinator, contact who can be contacted. And then we built a triage system. And as I think Mark was alluding to, we've got a 2-week, within 2 weeks to be seen once the PIFU has been triggered. The triage from the nurse specialist will coordinate what the most appropriate appointment would be for that individual patient. It's entirely at patient choice. We're doing this as a pilot, so we're doing this with some quality assessment built in, not unfortunately quite the level of research data that Laura will be collecting, hopefully, but we've certainly got sort of regular review and assessment. A weakness, have we sort of rolled this out in collaboration with our patients? I'm afraid we haven't, and I hold my hands up. But will we be seeking feedback from our patients and families as we embark on this journey? Yes, we will. And at the end of a 12-month period, we'll have a hospital-wide review of the service. I have colleagues in plastic surgery, of all things, who have a similar who are embarking on a similar trial here in Liverpool. Very briefly, we've shared our experience so far across our paediatric network. We've shared the protocols and the patient information that we give with patients, as I say, who have entirely the option to enter onto a PIFU pathway. So we're quite excited. We think it has great potential. Okay,
and presumably these are older children, little ones.
Yeah, so we've not put an age criteria, Ailsa, on this. So we've said that this must be children and people we've known for 2 years and whose disease is defined as stable or in fact in remission. We have a little bit more the luxury, I suspect, of following up and monitoring some of our children who've achieved remission, by still coming to see us in a hospital service. So parent-initiated follow-up, of course, is what we would associate most frequently for our patients. The voice of I sometimes refer to our middle-aged children or our slightly older children, ensuring that we hear the voice of that cohort, that group of young people who may perhaps want to initiate their own follow-up. That is something we recognize as really important, but of course that can be challenging, both from the young person's side, but also how we communicate directly with young people, and that's something we're very conscious of.
I can imagine that when you think about teenagers who are sort of maybe in the 16 to 18, starting to go into sixth form, maybe going to university and so on, I would imagine that, and they're in that bracket, which can, as you say, be very challenging. Well, I don't think I want to take my meds this week because I'm going to a party, I'm going to be drinking, or whatever it might be. I would imagine that that's quite a challenging age group to ensure that they don't fall through cracks and that they there is some way of monitoring them if they are on such a pathway. Would you agree?
Completely. So for all the children and young people who enter onto the PIFU pathway, we have a safety net of, at the end of 12 months, an appointment will be routinely offered. So as we do with it, our pilot, that currently is a safety net we built in, but of course 12 months is a long time. So we're particularly, I think, challenged as to how young people themselves can contact us as health professionals. We know that it can happen, but we know that equally that it can be challenging, and young people may not, in fact, in the age groups that you've said, actually be that comfortable for their parent to be the point of contact at times. So
yeah, and it is challenging, I think, sometimes, irrespective of what age they are, to take that decision that I'm going to contact the team because I deem I have a problem that's sufficiently urgent to do that. But let's move on to some questions, because I'm conscious that we could just talk and the time would be gone. So I've got two lots of questions here, but let's deal perhaps first of all with questions that have come in via the social media that we put out about this Facebook Live. And they're all anonymous, so there's no names associated here. So let me put the first question to you and see who wants to take this. Is there not a risk that removal of routine follow-ups will lead to long waiting lists for patients who do need follow-up care? So are we going to be adding to the backlogs rather than decreasing the backlogs? What do you think, Laura? Should I come to you first?
So I think in the research, that's the one thing that was consistent, that we seem to see less appointments, and hopefully therefore we're seeing appointments where people need them and not where they don't. And I think the advantage, and there are few, of the COVID pandemic is we have got a lot more savvy as patients and clinicians at using kind of digital questionnaires and monitoring and things, which will be helpful to keep an eye on people remotely. So from the research, I would say it would overall decrease appointments. So there is a chance that this will impact on the backlog. It depends a little bit what your kind of minimum requirements for PIFU will be. That's something we want to work on at the start of the study with patients and doctors, about if you call, how soon do you have to be seen, as both Mark and everybody's said, but also what your backstop is. So if you don't ring, how long do you wait before you potentially get that backstop appointment?
Right. So the next question, and maybe Mark, this might be one for you, as you presumably have got experience of this with your system and your team. Is there a risk that adverse effects of medication might be missed from blood tests if follow-ups aren't scheduled until the patient feels unwell?
Yeah, can I answer, just have a little tack on the end of the previous answer first, but then I will answer that. Is that okay?
Yeah.
So I think that the am I going to be seen if I press the emergency button, if you like, or that is so much down to trust, appropriate clinical, I would say clinical triage, if you like, and although I always seek to, and as a team in Plymouth, we always seek to fulfil the 2-week criteria, or within 2-week working week criteria. You'll understand occasionally it doesn't work, just because every system breaks sometimes. However, if it's a first contact that somebody's made with our service, or an early contact, or somebody who I know we're still, for some reason, whatever reason, trying to establish trust, I will seek to ensure that they are seen. And although I typically don't overbook in my clinics, really to maintain service not falling to bits, those are the sorts of circumstances where I will go, if you like, over and above, because if you like, there's a long-term win in that particular situation. So generally, absolutely, it's about being able, people feeling able to be confident that when they say help, actually something happens, or I've got this query, something happens. And I had that conversation even with somebody this afternoon who has had a few years of being completely well and really not needing us at all. And he came in and talked to me, and then at the end he said, well, I know things have sort of settled down, but I'm worried I won't be able to get back in. I said, well, how did it work this time? Well, I came in 15 days. He just happened to ring on a Sunday. He came in 15 days later on a Monday. No, it's not Monday today, it's whichever day. I've got my days all muddled up. Anyway, but it was about establishing, but it was about establishing trust with him and reinforcing that all the time. Coming back to the medications, the medications or side effects, it's a good question, and we need to be open to the fact that different things happen in different ways in different parts of the country. In the southwest, a lot of, for example, drug monitoring with, say, for example, usually blood tests, happens remotely closer to people's homes anyway. So we have quite a rural, there's about several hundred million people live in Plymouth, but there's a lot of people who live in more rural locations. So a lot of the, for example, blood testing happens remotely anyway. And for many, many years, we've had a standard sort of supporting service of our GP colleagues with standardized parameters. You know, if they're within these, it's okay. If it's outside, let us know. And for example, we have an email service. Will we never miss anything? I can't say that we'll never miss anything, but the reality is even the current system sometimes misses something. And I think with the right sort of conversations between different healthcare providers, for example, primary care, secondary care, that GPs and hospital care, we can work that out. But that's been one of the really great things of the last couple of years, is seeing people how they've worked across organisational boundaries in a way that at times didn't always happen, when there was a kind of competition between health providers, which doesn't always actually lead to very good collaboration. And typically, in my experience, certainly for physician-led care, medical doctor-led care, collaboration typically are the systems which work better. And for chronic diseases, I would say that's really almost always the case. So can we miss side effects of drugs? Yes, we might, but I don't think that would be to do with PIFU. I think that would be to do with other aspects of how we standardise care and delegate care to our colleagues across different parts of the health community.
Yeah, I would agree with that. I mean, normally, I know not everybody gets their shared care done through and blood monitoring done through the GP, but I think a majority of people probably do. And if it's not my consultant-led team that flag anything to me, it's my GP if my bloods are not within their normal range for me anyway. So next question, and anybody can answer this. How long do you envisage PIFU will take to be used across all rheumatology units? There's a question. How quickly, I mean, given that NHS England, at least in England anyway, have issued these targets, do you think realistically that these targets are going to be met by March 2023?
I'm happy to come in there if that's, I don't know if the others want to jump in. You can come in later on. Okay, targets by their very nature have the potential to skew clinical priorities away from what are actually best medicine. Now, I understand why targets exist, but there is no doubt that they have risks associated with them. However, they do make people sit up and think, and therefore they do, I think, sometimes drive conversations that might not happen, because typically, frankly, in my whole life, I tend to do tomorrow what I did yesterday, just because I'm a creature of habit. And that's the same with all bits of my life, including how I practice medicine. So when new things come along, sometimes it can be a bit of time to sort of get change. I would say a few things I would say about we may or may not meet the targets, and to me that's kind of irrelevant because I'm not a politician, although I realise that there are politicians for whom that's important. I would say that units finding ways of everybody going away with a good taste in their mouth with a first impression, i.e. finding a group of people where there is a degree of established evidence with the uncertainties and caveats that we've already talked about, and say, well, these are a group of people where we are pretty confident that they are going to access us. They've demonstrated that other ways, or we've talked about it. So if you like, we're pretty confident that unless something happens, and of course, you know, we can all sometimes not contact health services. Let's say I become depressed. You know, when I was depressed, I didn't contact health services, but my wife did on my behalf. So there was scaffolding around me to do that. And the analogous, you could do that to inflammatory arthritis. So finding a group of people within an organisation where you can have a degree of confidence is going to work, a defined cohort of people with certain diseases where there is a degree of evidence, I think is good, because then actually people get a good, you know, the providers of this care get a good experience. And even if you meet the 5% target or not, actually what you get is people thinking, actually, this hasn't been too bad. And there've been these unexpected benefits that perhaps we had thought of, and then these other things which we hadn't thought of. And then you can build from there. And although I know the pressures are bigger now, it wasn't just this seamless thing over 10 years in Plymouth. There've been little kind of going down little alleyways and trying things out in different ways, which didn't always work out exactly as we thought, but there've been a close circle of change with a collaboration across a number of different kind of parts of the health community and our patient partners too. So that's been, if you like, what I would suggest needs to be thought about as non-politicians in the health service, if you like, is find a group of people where actually it's most likely to work, so that, and then start to think about who are the people where it's a little bit more complicated, who are the people who can access health services, who do have the confidence but don't always necessarily for some reason have the capability of, or there might be some other uncertainties around it, where yeah, with the right experience in the health service and the right, if you like, support, and particularly over the next few months as the patient facing information and clinician facing information, I think it will get, I hope, dramatically better. Yes, you know, what we've got in Plymouth is a start, but it is only a start. And having really good educational materials which help us to be prompted to ask the right questions when we're being asked this, what do you want to be part of a PIFU process? Those sorts of things will help him, if you like, the collaborative decision making, or what we sometimes call shared decision making between a patient and or their family and the health providers. So we may or may not meet 5%, but I think that actually there is an opportunity here to really find a group of people in a certain area where we can make it work, and then deal with the slightly more difficult things, if you like, as we go along, and then incrementally over time get people with different sort of marginalized groups, or people who have different reasons why they might not find it easy to access healthcare. We can work out how we can best support them in the situations they are too.
Yeah, I think that really answers the next question, which is how will you check in on patients that may not have time to call and book, or may be unable to due to feeling too anxious. Now, I'm assuming that those kinds of patients would not be put onto this kind of pathway, because one of the things that we've certainly seen over the years in work that we've done in other research, if you are anxious, if you're not confident in managing your own healthcare, or if you are somebody who's feeling depressed, we know depression and anxiety are very high levels of those comorbidities in rheumatoid arthritis. They are less likely, therefore, to be good self-managers in that sense. And so we need to provide more support to people, and wouldn't put people in that category necessarily on this kind of pathway. Am I right? Yeah, everyone.
Well, could I just come back on that, actually? I'll let Laura come back first.
So at the moment, there isn't kind of clear guidance on this, and it's very much a shared decision making. It's a discussion with a patient. Hopefully the fact that you know your patient because you've already looked after them for a couple of years. These are not brand new patients. And so there's something that we probably currently can't measure very easily that is about that opinion. You know, the fact that you've known somebody for a while and you get the idea that they might be confident or they might not be confident. One of the things we want to do in the study is measure that using questionnaires at baseline when we're thinking about PIFU, so right at the beginning, and also once people switch to PIFU after they've had access to the education and the supportive materials that we want to develop. So there are questionnaires out there that are quite simple. So, you know, do you feel confident in managing your own condition? You know, not a lot, a little bit, quite a lot, very much. You know, simple questions. Are you happy that you know what your medications do? Are you happy that you can contact your medical team when you need to? So I think there are ways that we can manage that and measure that better. And that's certainly one of the things we think will be really important in predicting who is good for PIFU, who would do well on PIFU. And so it's something we hope we can learn from the study and then put into like a checklist. So at the moment, our checklist is, are they stable? Have they had disease for a couple of years? Are they not changing treatment at the moment? but actually maybe there's like 2 really important questions that are: how confident do you feel managing your condition? How confident do you feel accessing your, you know, healthcare team? Something like that, that we could put into a checklist that then doctors and nurses can use in clinic when they're talking to people about PIFU.
Yeah, absolutely. Does that cover what you were about to come back in on, Mark? Because I've got some other questions I'd like to kind of crack on with.
No, absolutely. No, I'm supportive of you doing the other questions. Thank you.
Okay, so one of the things that we've found in surveys and work that we've done is that when it comes to contacting other members of the multidisciplinary team, so we're talking about feet, podiatry, physio, OT, work issues, I can't undo jars and all those sorts of things that we struggle with. People often think that if they get a referral to a physio, for example, that it's a kind of a one-off thing. And we found that from a major survey that we did some years ago. And I am a bit concerned that, you know, because PIFU tends to be associated with consultants and nurses and accessing in extremis, I'm having a flare, I've got a problem with my meds, it's all kind of clinical medical stuff. But there's an awful lot more to living with rheumatoid arthritis and the impact and JIA and the impact that these diseases have on one's life. Will you, and maybe Mark, you could answer this, and Gavin, you could come in here. Will you be educating patients that if they just feel they've got a problem with their feet, they maybe need some custom built insoles or something, they can use that as a reason to be contacting the team? It's not just about, I'm having a really bad flare today. You know, what do you think? Gavin, do you want to come in on this? If you can unmute yourself.
There we go. That's the hazard of 2 screens. I just completely lost the mouse pointer then. I was getting into panic. Yeah, Elsa, what we've so the whilst the pathway for PIFU, if triggered by the young person or the parent, it will be a contact with a clinical nurse specialist initially. We've very clearly defined that if that triage suggests it's actually more appropriate for physiotherapy, for occupational therapy, for psychology, for another member of the multidisciplinary team, that's absolutely built in, so the patient will be directed to the most appropriate. We think obviously there will be a number of patients whose usual self-help measures in concern about their rheumatologic condition will trigger a nurse specialist or a consultant appointment. I say that we face-to-face within 2 weeks, but absolutely, we you know, triggering and forwarding on to those colleagues with the MDT is absolutely built into our pathway.
Can I, because there's still more, I'm conscious that we're coming rapidly towards 7:30, and I want to just quite get a couple of more things in. Would you both agree with that in terms of how you triage that appointment and encourage people to make those contacts if they do need to see members of the team? Because I think that's really, really important. The other thing that concerns me, and us at NRAS, and Claire and I have had lots of discussions about this over the last couple of years, is how PIFU is going to impact annual reviews. Because if you haven't got an appointment for 2 years and you've gone from having an annual review where things, other conditions, your mental health and all those good things are measured, so that, you know, things like cardiovascular risk, osteoporosis risk, and mental health and so on, these are all recommended by NICE to be measured at annual review. If you're not seeing anybody for 2 years, except when you need to trigger that appointment, how is all of that going to be done? Who's going to be measuring anything? Mark, do you want to tell us how you're doing this kind of measurement in Plymouth for people on that pathway?
Thank you, Elsa, for that question. That is one part of the pathway, if you like, that we're particularly focused on looking at now. Because if you like, a few years ago when we were implementing PIFU, we were trying to fix a problem, which was basically a burnt out health economy. I would, and I was talking with our lead specialist nurse today about how we're actually going to approach this in practice, but because the question for me is what it is we're trying to achieve. And I would actually, as you I think know, and so maybe Laura I think does too, I would actually challenge necessarily what the evidence is for the fact it needs to be an annual review. Now, periodic review of the types of issues that you just talked about, yes. It may be that for an individual person, then there are choices made for exactly the frequency of the follow-up. Absolutely, that's about personalising healthcare. I completely support and agree and think it's right that we have periodic review, but I would challenge the fact that it necessarily has to be annual. That's a conversation which is ongoing. But in terms of the principle of how we do sort of systematically look at people in Plymouth in a periodic review way, that's one of the aspects of our service which we're currently working on, because that's, if you like, been one of the good things for us as a service. Having other people coming and looking at us at the moment, it's great being down here at the end of a peninsula by all the beaches in a lovely sunny place, living, you know, on the edge of Dartmoor. But sometimes being down the end of a spoke, you are down the end of a spoke, and sometimes you're not quite so aware of exactly what's happening in even a few cities away. Yeah. So that's been a good thing for us to do. I definitely think periodic review is important. Quite what the period is, I think, is an open question.
Okay, well, I'm afraid we're going to have to wrap up there, and there's lots more. I've got loads more questions, but we've just run out of time. So I'm sure that we will come back to this maybe in a few months' time, perhaps once we've got a bit more experience of what's going on around the country and who's doing what. But before I wrap up and say thank you very much to our lovely speakers from this evening, I do just want to run off with a couple of things that are happening at NRAS to make you aware of. First of all, you will be, I hope, aware of our e-learning program, Smile RA. Well, we launched our new medicines module yesterday. Hurrah! So that is now up on the Smile program. So do take a look at that. And if you haven't registered for Smile, it's easy to do. Just go to nras.org.uk/smile and you can register. We've got a new booklet called Blood Matters. I don't know if you can see that. It's going in and out of the the background, but it's called Blood Matters, and it's all about blood tests and everything remotely to do with blood measuring and different things that are measured in blood and so on. And it was launched at the BSR, and it is absolutely pouring out of our door at the moment. The hospitals are ordering it in bulk, so it seems to be going down very well. So if you want one of our new Blood Matters booklets, please get in touch. Our next Facebook Live is on the 29th of June on the topic of psoriatic arthritis, so one for you, Laura. And it's going to be with the British Society for Rheumatology Biologics Register with Professor Gareth Jones, who's Professor in Epidemiology at Aberdeen University. We are running our first ever JIA Awareness Week on the 13th to the 17th of June, so next month, coming up very soon. Hashtag same JIA different day. So please watch out for that. It's going to highlight the fact that JIA is a fluctuating disease and no 2 days are the same living with JIA. Please see our website for more details, and that's our jia.org.uk website. And I know that Debs has been doing lots of wonderful filming and video making with young people, so there should be some good things to watch for that. We've got our hashtag Wear Purple for JIA Day on the 17th of June. So our packs are flooding out of our doors at the moment. So please get involved and help raise funds for our JIA services. Our online JIA parent and carer group meet on the first Monday of the month at 7 p.m. on Zoom. And if you'd like to get more information about that, just email jiaparents@nras.org.uk. And if you'd like more details of anything that's happening with JIA, then please sign up for our quarterly e-news or our new JIA digital membership. So lots going on, website for more information, but I'd just like to thank you all very much indeed for talking tonight about everything related to patient-initiated follow-up, and I'm sure we'll come back to this. So have a good evening, everybody. Thank you very much for watching, and good night.